We'll give everyone just a couple minutes to get in here. Happy Wednesday. Welcome everyone logging in. Give just like another minute for everyone to get logged in, and then I'll get started. Was everyone able to see the slides? Could someone come off mute and let me know?
Yes, we can see it.
Wonderful. Thank you so much. I appreciate it. Well, I think we'll go ahead and get started. Welcome, everyone. Oh, good. I see some thumbs up. Thank you for the feedback. I appreciate that. Welcome. I'm Dr. Allison Hanish, and I'm very excited to be here. This presentation today is an invited presentation from the MNRS Engagement Committee, and I'm very grateful to them for inviting me to speak today. I am working off of one monitor today, so I actually cannot see the chat. Melanie in the executive office, if you see the chat or anything pop up, let me know. But also everyone on the call, we have a smaller group here, so please feel free to come off mute and ask questions as we go. And I'm hoping I'll have plenty of time here at the end for some questions too. So today my talk is on self-care and preventing burnout. And if at any point during this presentation you're having trouble hearing or the text not working, again, please just come off mute and we'll troubleshoot that as we go. So before I get started, I'm just going to give a little general funding statement. Some of the work here that I'm going to be talking about was supported by HRSA, or the Health Resources and Service Administration, and the information and content and conclusions are those of mine and the team, and not to be construed as an official position or policy inferred by HRSA, the Department of Health and Human Services, or the U.S. government. So objectives today, we're going to take a look at the Dr. Lorna Breen Healthcare Provider Protection Act and a little bit about the process of where it is for reauthorization of that act, which aim to reduce and prevent burnout in mental and behavioral health conditions, as well as suicide among our healthcare workforce. I'm also going to take a brief summary of the National Academy of Medicine's National Plan of Health Workforce Wellbeing and give an overview of generally of burnout, behavioral health, and suicide statistics and its impact in nursing generally. And then I'm going to be spending a chunk of our time really looking at our implementation and evaluation of our HRSA funded grant that focused on student well-being. We also did practicing nurses, so I'm going to hit a little bit on that in this presentation too, with a focus on our actual program that we delivered to undergraduate students, which was Whole Wellness, How One Lives Effectively. So we're hoping by the end of this webinar, you'll be able to increase your knowledge about burnout in nursing and how it contributes, particularly to nursing vacancies and shortages. And we'll be able to apply the knowledge on the importance of individual and systemic wellness interventions by preventing, reducing, and managing burnout and behavioral health conditions in our nursing students, as well as nurses and advanced practice registered nurses. So let's get started. For those who don't know, Dr. Lorna Breen was a physician who died by suicide at the height of the COVID-19 pandemic. Her family has been instrumental in advocacy efforts related to burnout, mental and behavioral health conditions, as well as suicide in our healthcare workforce. There we go. Sorry, a little delay in the PowerPoint. There we go. From this came the Dr. Lorna Breen Healthcare Providers Protection Act. Currently, it's under a state of reauthorization. However, at the time, it was basically $100 million was as allocated from this bipartisan supported law. And what it did, it was allowed HRSA, which eventually was the person who ended up distributing this money, to have $100 million to allocate toward health workforce well-being. What's really instrumental is this is the first of its kind in terms of funding this level towards our healthcare workforce and their mental health and well-being. We were very, very fortunate at the University of Nebraska Medical Center to be one of those applicants. There were 34 funded through this grant mechanism. And I came to find out they had over 200 plus applicants. What that tells me is that this is a major, major issue, and there's a lot of people seeking funding to really figure out both individual and systems level solutions related to burnout, mental and behavioral health, and suicide in our healthcare workforce. I'll back up here. In terms of where this is at now, I actually just checked it out before I got on here. Again, this was a bipartisan supported law that allocated money. It has since expired and it is looking for reauthorization as of February of 2025. It looks to be that it was introduced to the House and then sent to the House Committee on Energy and Commerce, where it seems to be sitting there for a little bit. I know we have a lot of issues going on right now in our country and world. However, there is continued bipartisan support when you look at the co-sponsors of the bill. They are really across both aisles, and we again continue to write, and I'll put some in the chat at the end of ways you can reach out to this. Basically, reauthorization allows additional funding mechanisms to happen. They have switched a little bit in some of the areas that they're looking at. A lot of this is on basically some of the top drivers of burnout. We're looking at administrative costs, the burden, the bureaucracy, the paperwork, those sorts of scenarios where we can help to reduce burnout and behavioral health. I'll stick that in the chat at the end of this presentation so you can see ways that you can be involved in terms of potentially writing to people who have some say in Congress. In addition to the Dr. Laura Breen Healthcare Provider Protection Reauthorization Act, there's been many national plans for what we should do for health workforce well-being. This is a very, very big problem that has many solutions, but I want everyone that I come in contact to know that we actually have really well-made guidelines already existing, and it is really a matter of looking at them and implementing them and seeing how they can work in the spaces that you're at. I'll also put in the chat, but you can just drop it into Google and easily assess it. This National Plan for Health Workforce Wellbeing it came out in 2024. I think there might be an updated one for 2025. There's a way to download that so you can see that, and I'm going to go over high-level details of that today. I think what really struck me about this, and after spending 4 to 5 years now in this workspace, is this statement that's at the beginning of this document. What it says is, knowing is not enough, we must apply. Willing is not enough, we must do. And that struck me because as a background, this is, again, I spent the last 4 years in this grant, but my background is actually a pediatric sleep researcher. I came into this space at the height of the COVID pandemic. My husband worked COVID units. I lived within a couple miles of the only state medical center where my husband worked, and all of our friends and family, frankly, seemed to be linked to the healthcare workforce. And I watched it just decimate portions of my family, portions of my friends' family. I watched people suffer publicly, and I watched people suffer in silence. And I thought to myself, what can I do to help? And I felt really stuck, not working physically in the hospital, but sort of watching around me implode and explode in many ways. And the Dr. Lorna Breen funding came through. I saw how important it was, and I remember going to our Dean Sebastian at the time and asking her, "Is there a way we can put together a team to try to figure out ways to tackle this problem?" Again, my background's in sleep. I've learned since this study how important sleep is to burnout and well-being in the health workforce also. But she came to me and said, "You know what? I think you should do it." And that was not necessarily part of the plan of my life and where I go, but I say these things to anybody on here. that sometimes in life there's some pivots, and I've come to know over the past 4 years that this health workforce well-being is everyone and no one's issue. And by that I mean we are all impacted, but really there's not singular people that are in charge of making these things happen. It's really a large systems level issue that takes a lot of different people to tackle. And one of the things I really enjoy doing is putting teams together and valuing all of those opinions together to try to solve systems level solutions. So if you're interested in this work, but maybe even haven't started it yet, I think everyone has a part to play in it. And again, back to this quote, knowing is not enough. We all know that burnout and mental health and suicide are major issues in the health workforce, but we must start applying these things and not just being willing to do it, we must actually do that. So we're really at the action phase of the well-being parts. When you look at this document, um, you can assess it online. Again, you can stick it into Google. I'll stick it into the chat at the end. But this is the high level summary of this. It has different priority areas as a national strategy for us to tackle these problems that we're talking about. One of those priorities is creating and sustaining a positive work and learning environment. That's really important for any students we have in this call, both in the academic side and as you go into practice. The second priority area, which really I love as a researcher, is how are we investing in measuring things? How are we assessing them? What sort of strategies are we using for measurement? And what research exists in this area? The third is an area that the Dr. Leonard Breen Foundation has done fabulous on is how are we supporting mental health and reducing stigma in terms of seeking help for those who need it. I think we've come a long way in terms of reducing the stigma related to this, but we have a ways to go still. This fourth area, which I'd mentioned a little bit earlier, is sort of the new focus of that Dr. Lorna Breen Provider Protection Act, hopefully in the reauthorization stage at some point, was to address the compliance, regulatory, and policy barriers for daily work. This is a major issue, and it's often reported as one of the highest things related to burnout in our nursing workforce. What do those look like, and how can we address it? Looking at engaging effective technology tools. I think in the recent months and years, the use of artificial intelligence. What are we doing with AI? Looking at EMRs, how is that impacting our well-being? And the last, institutionalizing well-being as a long-term value here on this slide. As you can see, these are involving a lot of different people. You have stuff from the educators and the environments that you're working at. You have people developing measurement strategies. Are we even measuring the right thing? Is a legitimate question. And what changes are we seeing when we start to invest in programs related to health workforce well-being? The stigma and policies. I'm going to talk about some of the work we did working with the Nebraska Board of Nursing, but what are we doing to make sure people can seek help? Because even if we provide those resources and we give people access to mental health professionals, do they want to use it at the institutions? Do they want to use their own support? Are they scared that they're going to be reported for using those services? And do they think it may impact their ability to continue to practice? I can tell you this was a major focus of the Dr. Lorna Breen initial and their advocacy efforts currently. Dr. Lorna Breen's family believed that she died by suicide because she feared seeking help, because she feared that she would lose her medical license. And that is something we have worked really, really hard on, making sure that people can access the supports they need. When you get into policy barriers, those are going to be local, regional, national, international. What are we doing for that? How are we incorporating techs? And then you've got the informaticists and the people running the EMRs. These are a lot of different people and a lot of different ways to engage. What I like about this document is it starts to tell you what the priority areas are from a national level. Who are the people involved in those priority areas? Here you can see academic institutions, healthcare systems. You can look even further into into the insurers and who's paying for our healthcare. In addition to the goals, it has actions. What can we do? I think this is what I love about this document is it really starts to operationalize what are the things we can do. One of those things here listed is instill approaches to decrease workplace stress and burnout, looking at learner well-being. How is that being implemented at your organizations and where you're at? And if I have students on this call thinking about is it incorporated into the courses that you're having? What could we do better at the learner end of that? Looking at your strategic plans and your organizational values, the HR policies that people have. What do those all look like? And are they in them first? And if they are in them, are they actually doing anything about it? And I think that's one thing I found as I've done this work is even if they're in that strategic plan, is it being used as a checkbox? Or is there actually someone in these organizations in charge of really making sure these things get enacted and then making sure they're being assessed that they're actually working? One thing we did is we did well-being onboarding programs for our students, and I'll be talking about what we did for that in our student end. Looking at training opportunities for faculty. This is a major issue for us. I can tell you in Nebraska, one of the most startling statistics I saw was actually some of the highest rates of issues are among our faculty in terms of mental health, with 90% plus on our licensure surveys that we do, reporting incivility and workplace violence on their nursing licensure. This is something we do every 2 years for nursing renewal licenses. And again, faculty, we're at highest risk for that, even above the nurses and other roles. Again, the actions are listed here. You can take a look at these. What I love about that national plan is it really goes all of sorry, my slides are delayed and moving around a bit. I went over all the different priority areas. You can look at this. Every single one of those priority areas has like the snapshot that I showed you there. They have priority area goals, different goals related, who's involved, how they interact with each other, and what are actual tangible things we can do to help. I think that sometimes when we talk about well-being and mental health, behavioral health, suicide, people don't know where to start. I get this question often when I give presentations like this. What can I do? I'll hear I'm just a student, or I'm just a nurse, or I'm just a supervisor. Where can I influence this sphere? And my answer is we all have to take a piece of this puzzle. Again, at the beginning, I mentioned it's an everyone but a no one sort of problem. I believe that everyone has a role to play in some of these actions, and just taking one piece of that puzzle and starting to work on that in whatever space you're at has value, and that's a way we can start moving these actions forward. So generally, when we talk about burnout, behavioral health, and suicide, every day there seems to be a new publication out with this. So I'm just going to give you ranges of this. What we know is that nursing vacancy shortages, recruitment and retention issues, when we start to look at burnout rates, I'm seeing anywhere from 50 to 80% plus. Those rates are all going to be dependent on the unit, on the organization, where you're at. I think at the beginning of COVID, we sort of thought that this was going to be the height of it and things were going to get better. It does seem as a general statement. You can find lots of different studies, but the pandemic did seem to exacerbate these things. But these were issues well before the pandemic, and they continue to be issues well beyond the height of the COVID pandemic. We did see escalations. However, these issues are still major, and we still need to work on them. I think one thing that's not talked about enough is that the suicide rates for nurses are well above that of the general population. And I think it's something we need to take seriously in what we're doing about that, and how we can improve the mental and behavioral health state of our health workforce to improve that statistic there. I think the more I've given talks like this, people often ask about psychological safety. And so I'm throwing it in here. We know, I'll back out with burnout. So before I get to that, I think burnout itself, when you look at definitions, you're actually going to get a lot of different definitions. And some people adamantly believe it's an occupational syndrome. Some people have moved into being beyond just an occupational syndrome and suggesting that you can't separate burnout from an occupation versus your overall life. But when you think about burnout as an overall occupational syndrome, typically the definitions you're going to get are feeling energy depletion, feeling exhausted, feeling some sort of mental distance from your job, feeling negative, feelings of cynicism. What we know is all of this decreases your professional efficacy and your ability to do your job. I say that as a definition first before I move to this because these are separate but related. Psychological safety has become, in my opinion, a sort of catchphrase. But when we start to look into what that means, it's how do people feel safe in taking interpersonal risks How do they feel safe speaking up or disagreeing openly or generally being yourself without sort of repercussions? This is sort of that culture of safety that we're creating. I think sometimes where we get into issues is actually some of the symptoms of burnout that we've talked about, feeling that cynicism, negativism, exhaustion. Sometimes that doesn't lead to very psychologically safe environments because people are not behaving maybe as they would if they were not burned out. And so I think that they're actually much more related. And psychological safety has sort of moved on. I think burnout has sort of moved on to the psychological safety space, but they're related. And so, how do we work on this psychological safety? And this is a question I'll pose to everyone here at the end too. But how do we create these psychologically safe environments? How do we create classrooms and clinical setting and workplace environments where people feel like they can generally be themselves or they can speak up without fear of repercussions? And this is a major issue, I think, in nursing. And when you start to look at the workplace incivility between nurses, it's high. We have really high rates of this, and people are afraid to speak up and to be themselves. And so I think we are tasked to fix these problems and get some solutions here. Sometimes weaponization of psychological safety can happen. And by that, I mean, people will say things like good vibes only here, and you'll get these toxic positivity where, we don't want that cynicism, one of those things of burnout or the negativism. It's not, well, that kind of counteracts some of this psychological safety. If people can't be themselves, if they can't speak up, if they can't say when things are going wrong or not going right, um, that isn't psychologically safe. So being positive all the time and having good vibes only all the time is in some ways in opposition to the psychological safety thing. So we need to really think about that and what we're doing to create those environments. So I'm going to leave that for a second to just give you a taste of sort of the terms that are out there. We've kind of gone over, the funding that happened related to health workforce burnout and mental health. We've gone over sort of the laws that have been passed to work on that, what burnout looks like, what psychological safety looks like. And I'm going to talk to you a little bit about what we did because it's hard. These are really, really tough problems to tackle. And I'm going to tell you in full transparency, I do not have all the solutions or I would offer them all to you. But I can tell you those things like the National Academy of Medicine's plan for health workforce well-being really gives you a blueprint of how you can start to tackle it. And I'm going to show you how we started to tackle it on our 4-year grant. So our HRSA collaborative grant really focused on burnout and behavioral health as a multidimensional construct, really looking at both individual and systems level action. It was really, really important to me at the beginning of this journey that I did not try to blame individuals, or even though the grant was about resilience in some form, that it wasn't an individual fault. I strongly believe that individual interventions are necessary, but they're insufficient to target burnout. We need system level action, and so we did what we could on the systems level as we did these agenda items. I still believe, and I believed at the beginning in this grant, that we need a broad, whole nursing career focus on wellness to address burnout and mental health conditions. I'm going to share you details of my work, but I know we have issues with students prior to entering nursing school. We have a lot of stress. We have a lot of mental health and behavioral health issues before entering nursing school. We're putting nursing school, I think all would agree, is a stressful experience in itself and extremely rigorous. And I think we, as faculty and as institutions and as systems, we have a duty to help with that scenario and not just continue to pile on. And then we graduate from nursing school and we go into practice and more is piled on. And what are we doing at all of those levels across the nursing career? And I'd actually, as a pediatric nurse, I would say we need to start this well before even into the kids age of this, to focus on these conditions. But we really need to start integrating a more unified whole nursing career focus. We know that there are innovative evidence-based wellness programs out there. There's lots of different delivery models. I think, like I mentioned, that quote, that National Academy of Medicine thing, we know a lot. It seems to be we are a little bit stuck in the action part and what we're doing to actually solve these problems. And in our case, we chose a statewide collaboration. Rather than looking at a singular institution, we really looked across the state. For us, this was done on, there's even more people than on this list, but this was done with a 25 plus person team to enact our grant related efforts. We also worked with the Nebraska Board of Nursing, the Nebraska Center for Nursing, and the Nebraska Hospital Association to implement our programming. Well-being is not just an individual sport, it is a team sport. There are many people involved as we did this. We went through the College of Nursing level. We also worked through the Information Technology Services level. We worked at different campuses across the state. We looked beyond the university that I'm employed by to other nursing campuses across the state. Again, the Board of Nursing, Center for Nursing, the Hospital Association. We spent a lot of time working with our critical access hospitals across the state, particularly serving medically underserved areas and our rural areas, as we found there was a lot more well-being programs being implemented in our urban academic medical centers, but they were getting less service opportunities in our rural areas. And so we focused a lot on those areas. So when we look at this grant as a whole, it was a 3-year grant. We got an extra year extension on it, so it ended up being 4 years. Our overall purpose was to deliver wellness-based interventions and resources to address and reduce burnout and mental health conditions in rural medically underserved areas across Nebraska was our focus. We worked with undergraduate and graduate nursing students, as well as practicing registered nurses and advanced practice registered nurses. We had many aims in this study, but the first aim really focused on the student end. And this is when we talk about what are the resources out there, this would sort of be like the self-care portion of this talk. This was the program that we went with, and that was Whole Wellness, How One Lives Effectively. This was a program that was developed by psychologists and psychiatrists at the University of Nebraska Medical Center that we use rapid cycle quality improvement, which is a term to mean we updated it based on the feedback we got from the students to deliver this program. I'm going to talk a little bit about that, but that was delivered actually prior to students starting in our nursing program, sort of about that orientation phase. We did a resources campaign that I'm going to talk about. We delivered mental health first aid. We delivered content related to critical incident stress management, and we implemented, and actually this was full circle, has been funded now by the university, a student success software platform that we utilize. These were all focused on our undergraduate nursing students. So when we look at wellness training, in terms of self-care could be a word that you could also use here. This is what an example of what our program looked like. We had, in the end, we ended up with 5 sessions. What we found is that students wanted the content. It was very favorable in terms of our feedback. However, the time is always a tricky thing. And I think with any of this wellness content, it's trying to figure out what is the best way to deliver it and the time that works that's actually going to give you that impact. So we really started to look at the quality of what we were delivering and what is sort of the sweet spot for time that we could get available by still delivering the content. So topics that we would do related to this would be the stress response, looking at things like sleep, which was actually the highest ranked module that we did. How are students getting enough sleep? What I know from all of my research and actually directly from our students is that adults are not getting enough sleep every night. Our students were averaging about 6 to 7 hours per night. Typically, our adult populations are needing closer to 8, 7 to 8 are in the guidelines. But consistently, our students were reporting inadequate amounts of sleep. So we talked about sleep and how and ways and strategies to do that. Optimism and pessimism. We talked about things related to time. Time management was a huge thing for our students. How are we going to find time to get all of these things done? Having people physically write down all the things that they needed to be doing and how much time they can devote to them. Things like decluttering and how to keep your life and things straight so you're not constantly feeling like things are dropping and things are a mess, and what can we do for that? Finding meaning and purpose. This was a big one, and that's actually in the National Academy Plan too, is what is the meaning in the work you do? What is the purpose? What we have found in some of our data, I don't think I'm going to share this today, but our students come in, all health profession students actually at our university come in with very, very high meaning and purpose to start, which makes sense because we're in the health professions. However, over time, this seems to drop. And I think that's something that's concerning to me because when we start to lose our meaning and purpose in what we do, to me, that's sort of a red flag of potential burnout and potential mental health issues. And we're seeing that already in the academic setting where that's happening. We go into things like meditation and creativity. We've done some exercises. I'm a big fan of creative writing, and all the positive things that can come from that. We have people come in and talk from who have expertise in the creative arts and what we can do. And then, sort of the general things that you think of with well-being, with exercise and nutrition. I already mentioned sleep. This is sort of the overall. I could spend the whole time talking about what we delivered here, but that gives you an idea of the things that we did. So we focused on personal wellness, reducing the effects of chronic stress. Um, the whole thing is based on acceptance and commitment therapy, which I think was a very good avenue to look at, is looking at the things that you can control and the things you can't control, and what are you doing based on that. Imposter syndrome was another one that we touched on that seems to be a popular topic from students. One thing that worked really well is we had students develop a wellness plan at the end of this, and in it, they wrote down their goals for the year moving forward. We were actually able to upload it into our software system that I'm going to be talking about. And so our academic success coaches were able to talk to students and follow up with students to see, what are we doing and how can we support your wellness? So there's actually somebody responsible for following up with the students' goals while they're here and getting them the resources they need to meet those goals. This sort of hit all the dimensions. If you're familiar with SAMHSA, their dimensions of wellness, this sort of hit at all the different dimensions there. This is all data based on one of the cohorts we did. Really here, what it's getting at is we had a little over 200 students participate in this. We did do questionnaires with the students. It looks like a lot of questionnaires, but it actually ended up on average taking them only 10 minutes to do. We did this over 5 different time points. We had students complete this at baseline, so that was actually it was like 2 to 3 weeks before they started nursing school. And then they did this at the orientation phase at the end of the program. We did that at 3 months, 1 year, and 20 months, which was actually their graduation time point. We've delivered this, probably is on a slide somewhere, but to over 1,500 students were offered this. I felt very strongly that this well-being work should be optional. So these were all optional to students for them to participate. Uh, what we did for here was we looked at things like adverse childhood experiences, perceived stress. Life orientation was actually one that improved quite a bit with our program. So, that optimism, pessimism sort of scale. Acceptance and action questionnaire. This has to do with psychological flexibility, and that actually really matches well with the acceptance and commitment therapies. And we saw some improvements in that with our program. This grant did have some resilience measures in it. What I found is our students come in quite resilient to start with. And so some of this data related to resilience training, it makes me pause a little bit in thinking about it, even though that was sort of part of the grant. Our students are quite resilient to come out at the start. So I think that is something we need to take in mind. We have the burnout inventories, and we did things related to social isolation, sleep, depression, anxiety. And generally satisfaction, we are very open to having our students talk to us about what they wanted to see changed in the program, and we implemented that feedback throughout. Lots of data here, but the take home is uh, our students really, again, started out, they actually did, it's actually segmented by certain populations, but we did have a chunk of our students, I would say 20% or so, that really were more concerning on that burnout to start. So again, this would be before they started the program. This is all baseline data. When we look at the means for promise metrics, the means for an average population are closer to that 50. There's a T-score for that. Really, the one that popped out was we had a chunk of students who were elevated on their anxiety scales, which matches the literature before they started. We also had a large chunk of students, And I want to say it was high, like 80% plus had high levels of perceived stress before they started nursing school. We took that life orientation stuff, and I mentioned we did see some improvements on our life orientation, which makes sense with that optimism. We did see some improvements in that acceptance and action questionnaire, meaning bad things can happen. What are we doing with our psychological flexibility to move past those bad things in a constructive way? We saw some improvements with that, which matched a lot with it. This program, I mentioned it was delivered at orientation. We started out with about 8 different sessions, ended with closer to 5 different sessions. What we found is that people, while it wasn't necessarily some of the contents of the program, even though like sleep was rated really high and other aspects, the students really made a lot of comments about camaraderie and enjoying meeting people and feeling belongingness before starting nursing school. So getting to see people before, feeling like people cared about them before they got here. It also stood out to me that we need to know that some of these things are an issue prior to students getting here, and what resources are we doing beyond just a short 5 to 8 week session throughout the nursing program to concentrate on nursing student wellness. Some things we did work on is we worked on student resources. Our grant did a lot of combining of people, like how can we get our academic success teams and our academic success coaches to work, with the students on the wellness stuff? How does that connect to our counseling and psychological services area? And including financial aid, getting food pantries and food pantry establishments with that, going into financial health and how the financial aid office, making sure that all these student resources were readily available with all the contact information to the students. We did things that tried to promote, some sort of belonging and getting people to interact with each other. We've done things like gingerbread contests and pumpkin contests. We established well-being spaces across the university. I say this very seriously. One of the hardest things I did in this entire grant was getting the institution to paint walls a different color. So we had this like tranquility green, I think is what it was called, for this wellness space. But we're a 5 campus system. We were able to get space, which is hard to get at universities, for wellness rooms that have things like the massage chairs, light therapy, aromatherapy, snacks, positive encouragement things. And then to add to that, the students were like, we need more study spaces. We listened to them. And since these wellness rooms are actually highly used as study spaces and relaxation spaces, we were able to get additional places that we can have for study spaces for the students. We also did virtual reality related scenarios and looked at well-being. And that's sort of a picture there of some of our VR related scenarios that we did. Other things we did with students, this was highly effective. We delivered and paid for credentialing for mental health first aid for multiple years of our nursing students. While this targets how you help others, I think it provided a really good avenue for how nursing students can help each other, meaning their colleagues, but also some insight into some of their own mental health related feelings and how they were caring for themselves and what to do if they got into scenarios where they were not, they were needing some help in the mental health and behavioral health space. And so this was fabulous in terms of the feedback. This is a national organization that does this. We were able to administer their national questionnaires, and for the first time in my career, we saw statistically significant improvements in every single question. Things that stood out to me, it's not just a knowledge thing. It was that people were reporting, like, I'm going to give an example of averages here. If it was a Likert, if it was a scale of 1 to 5 of how comfortable do you feel about talking about suicide with people, we had a lot of people near that middle, that 3, that feeling of like, I'm neutral to it. I don't feel one way or the other per se. Some were on the more uncomfortable end, but by the end of the training, we were seeing higher rates in the 4 to 4.5 range, meaning people were more comfortable talking about suicide, about asking people, do you have feelings of suicide right now? Helping people get resources, but also helping themselves and colleagues in that realm. So again, I'm a high proponent of this. The mental health first aid proved to be quite successful for us. As part of our programming, we developed various e-learning modules. So we looked at critical incident stress This is something that came up a lot with our students as we did some of the well-being programming. Um, in many cases, they were put in scenarios, particularly in the clinical setting, where something critical happened. And it didn't have to necessarily be life or death, but some of the examples we did give were that. Um, for example, one of our students commented that when they were in the clinical setting, their preceptor and them were the first to deliver CPR. This person ended up dying. The emotions that come with these high stake critical situations where things don't go necessarily as planned. What are we doing about that? What are we doing as an academic center? The person who would be maybe your preceptor or the clinical person, clinical faculty, is debriefing the right thing to do? How are we debriefing? Are people doing it in a standard way? These sorts of major things that happen, and typically the reports were in the clinical related setting. What are we doing to do that? And because we feel strongly that these are touch points that can cascade into various other mental health related issues. And we are in a profession where critical instances or things that are of large importance do happen. And it wasn't always the life or death thing. Some things could happen that really struck somebody, and it could be on a personal level or their past experiences with things. And so we developed these modules that provide training to faculty, but also to students about what to do in these sorts of situations. And then I mentioned this is one of the highest successes we had, and this is a systems level intervention. And I hope more universities and more programs continue to adopt these sort of software platforms. So we had developed what we call Nursing 360, which was a student success software platform. And this is sort of what it looks like. It's actually embedded in our learning management system of Canvas, and it's very easy for faculty to get to. But what this does is it allows you to track students and get students the resources that they need over time. So ways we can do this are you can send that alert, you push that little life raft thing, and on that it'll pop up to me as faculty and you can select a student and you can basically tell you things you're concerned about. Are you concerned about their well-being? Are you concerned about, say, their exam grades? Whatever that concern might look like, that then goes straight to our academic success coordinators and coaches who then reach out directly to those students to provide them the resources they need. It provides a documentation system for us to have all of these things. It provides a way for us to really analyze what resources are we delivering? What resources do our students need? If we're starting to see a whole bunch of concerns about, say, financial related issues, what are we doing to fix those problems? Up until this point, there's a lot of, anecdotal evidence or people saying, oh, my students need this, or I've heard this, but we had no documentation about what we can do to improve student success. This allows us to do that. It helps us identify our struggling students early. I can flag students early on. If I have students, not do well in the first quiz or two, I can identify them early on, get them to the academic success coordinators, help them recover and retain those students by documenting this and to get them the support services they need. This allows us to enhance our campus collaborations across the state. And it really starts to build our best practices based on evidence. I say this is sort of like an EMR. It's like sort of like an electronic record of students, but how are we supporting the students? And it's not meant to be punitive. It is meant to be success. So it is a success platform. What are we doing that can help them? And what services did we provide? And I can tell you that this provides really, really great data in terms of retention and identifying our at-risk students early on in the semester. Because if we're starting to identify them by the time the first test or two has happened and they've already failed them with our policies and procedures, it is very difficult to recover after you fail those first couple tests. So this gets us earlier. It provides care teams, so we can start to put people on personalized scenarios and streamline that communication to get them the resources they need. It starts to eliminate some of our systems barriers and how we're duplicating efforts and these like disconnected late interventions that aren't really helping us and start to empower people to solve these problems earlier. It allows us to identify trends, develop strategies for more targeted interventions, and really, again, measure that key success and how students are really doing. As just a high-level student summary here, we've delivered that whole program to over, I think we're even higher than this now, but at least 1,400 plus students were offered this program. We had over 50% participate in nearly all components of the program. I'm really happy with having that sort of level of engagement with the program, and by and large, the feedback has been really positive. We've had over 500 students complete that mental health first aid certification, including faculty and staff who also did that. We've delivered those e-modules related to critical incident stress, and again, delivered that student success software platform. I'm going to very quickly, so we have time for questions, just go over a couple of the other aims of the grant that we did. One of the aims is to really deliver no-cost continuing education to our healthcare professionals across the state. We had over 550 people participate in our Heal the Healer, what we called them webinars related to health well-being. And this one of the main topics people had when we asked for feedback, they wanted to know about enhancing workplace culture. How do you improve communication? We recently had Dr. Cynthia Clark come and talk about workplace incivility. What we found is that by and large, when we looked at their changes in knowledge and what that looked like pre and post activities, that we're seeing lots of statistically significant good things in terms of promoting health and well-being. We also delivered psychological first aid, which is similar but a little bit different than mental health first aid. And that whole program I just talked to you to our actual registered nurses and advanced practice registered nurses across the state. We use this ECHO model, which is an all teach, all learn telehealth model where we can basically use Zoom features to engage them. It was really important to me that when we delivered programs like this to our practicing nurses, that they were not asked to do this above and beyond their job requirement. So the grant actually allowed us to pay facilities to then be able to buy out their time for people to participate. This was really, really successful. Here's some quotes from the people who participated. Working in a rural critical access hospital, this whole program was a cultural catalyst for our organization to put nursing wellness in the forefront. It validated our experiences as a nurse and gave us a chance to process the challenges we have endured. This was a big one, the second quote. This came through on many of our evaluations. I was finally able to reflect on myself after so many unprocessed hardships and traumatic experiences related to nursing during the COVID pandemic. Again, I don't think this whole program, when I don't want to oversell it in the components, but I think it really gave people an opportunity to come together to talk about some of the issues and process those issues and realize in some scenarios that they actually did need some more help than they were getting. This last little part, I mentioned critical incident stress is uh, is a topic area, but what we did across the state was an interesting thing. So we actually partnered with the Nebraska Hospital Association and the Board of Nursing to see how people were handling critical incidences within hospitals. So what did it look like when these big incidences happen? For instance, we'd hear in our rural facilities that a colleague or a neighbor or somebody that people knew really well came in and died. And what happened after that? And who's debriefing the employees? Who's giving them the resources that they need? And often these people that were in charge of this sort of leadership role also knew these people and were also embedded in it. So what was the state doing to sort of help, particularly these rural facilities, do this and manage sort of these crisis interventions in this sort of psychological or emotional first aid sort of space? Well, the state was doing this through trying to set up sort of local teams that could come in and help out. However, it was funded through actually state dollars from seized drug money. So we ended up going back and finding out like how these things are funded is often a little bit convoluted and not very continuous. And so we actually went in and tried to deliver this training and to try to figure out how we could help with critical incident stress management and how to handle that in the settings. I can say that this was kind of one of our failures of the grant. It's very difficult to do this space in rural communities and set these things up without continuous funding to do that. And so I think one of the take homes from that would be when you get these interventions, and even though I actually believe this program was well thought out, unless you have a way to sustain it afterwards, it makes you feel it made me feel as a person a little bit like, what are we doing coming in, delivering these content areas and this information, but not having a plan for it to continue beyond that, the grant efforts. So I think this was a good eye-opening experience to me of how we work with the community, how we work with facilities and institutions, and who's funding this stuff, and how can we promote sustainability even when you get a program that may be of some help. One of the biggest things, and then I'll wrap up here for questions that we did, is we were the first board of nursing to receive this award. So this is full circle for us. The Dr. Lorna Breen Foundation does this well-being first champion badge, and we got it first in 2024, and we've actually been renewed in 2025, and hopefully we'll again here next year in 2026. We worked with our board of nursing to remove any intrusive language related to mental and behavioral health on our licensing applications and credentialing applications. What that means is that back to Dr. Lorna Breen and their family's concerns, as they believe she died by suicide for fear of losing her medical license if she sought help. These systems level issues matter. And so when you have questions that are intrusive or overly intrusive, and in many cases they're against the American with Disabilities Act, about asking in the license, it makes people feel like they can't seek treatment. So we worked with our board of nursing to remove all those questions, and I've been working with our nursing students as well as our faculty and staff and the organizations to make sure this knowledge is known, that people can seek help without fear of losing their license. So I'm going to end with that. It was a lot of different information, but I will take any questions anyone has related to this presentation. And thank you for your time. I really appreciate it. I know it's a very busy time of the semester. Thank you. Any questions? I'll give it just a couple more minutes for anyone to think.
Allison, I know that you were working on just one computer. Ariel did have to drop early,
Okay.
but she did say thank you for the presentation. She is especially intrigued by the thought of having students develop a wellness plan for themselves as part of their program that is regularly discussed.
Thanks, Melanie. I just saw, now I can see the chat. That's perfect.
Oh, there you
Yes.
go. Good, good,
This
good.
is this is something that actually worked really well for us. One of my concerns was, so you deliver a 5 to 8 week session program largely before they even start nursing school. Like, who's going to follow up with them, and how are we going to document that stuff and the things that the students cared about in particular? And so, yes, the wellness plan, yeah, we'd be happy to share it, but it basically asks students to pick different areas that they are interested in improving for themselves and set actually tangible goals for how they're going to work to improve that. So say that their sleep was really important to them, and one of their goals was that they wanted to make sure that they got 7 to 8 hours of sleep per night based on some of the content we gave them. They would then think about those action plans and what they're doing it and how they're going to do it. And then we were uploaded them into our student success software platform. And so our academic success coaches who work with these students, I'm not sure if everybody has them across the country, but they're fabulous. Their role is to support the students in their academic success and well-being. And then they can check in with them. They actually used them. They have one-on-one meetings with all of our students. They used them as a starting point of like, how can we help you? If these are things that came up that people didn't ask them at the beginning. So we had people like they were highly concerned about their finances and how they were going to pay for textbooks. Well, or how they, frankly, how they were going to pay for food. If we can get those things early and try to help some of those barriers, it became a conversation that we can help provide resources for. And then aggregate seeing trends, like what are the things our students are most wanting to work? And that helps us deliver programs. Yes, the whole program kind of had a lot going on with it, but it allowed us to touch on little bits of everything, and then we could see what our students needed. Heather, I see your question too. How can we expand to other states or universities? Oh my gosh, I love this question. Um, what was interesting about this being a HRSA grant, and I say this as a researcher, We did not take this as a research project. We took this as a quality improvement project, and I think that we have made some strides in making our ability to have our whole program accessible to other people, and it is something that we could deliver to other people. I am still working on the data analysis of this and getting it published. There are some evidence behind what we're delivered. In terms of a good place to start, I think spending some time with groups and getting all the players involved is a start. So thinking about who at your university and in your department is doing this. For us, a lot of it was coming from our student services and our academic success support services. Talking with them, getting the counseling and psychological services people um, together in the same room, getting the leadership in the same room, getting the students' input in the same room, and really taking an inventory of what you already have. I think a lot of things are going on, especially in academic medical centers, and there's often not a person deciding what resources do we have and how are we handling this. That took us about 6 months, if I'm honest with you. And that was one of the things we did is put together that resources tab because it's confusing. One of the feedback we got from students is like, this is overwhelming. There's too many resources. That's actually what many students told us. There's too much. I can't spend my time going to all these different resources. But if you put them together and have people in charge of them, for us, it's the student services end of it, those academic success coaches, how can they funnel all those resources down to get the students what they need? I think that is how I would start, is managing what do you have, and then what are the gaps. It took us a full 4 years to get that student success platform up and going. However, it was the greatest thing we did. And that happened because I listened to the student services department on what they needed, and they said they needed a coordinated effort to track this information. It took us a year and a half to get this through our university and IT department. These things are extremely time intensive, and I can tell you with 100% certainty, without the amount of money we had in this grant, this would not be something that would have been implemented right now in the current funding climate. So the other thing to get started is how can we get university investments in time and money to get these things built up? I can tell you now we fed it in, all this data gets fed into our accreditation now. We can track our students. It already actually has their grades coming in, when we lose them in the program, what services are provided to the students who we did not retain and why. And it provides an enormous amount of data that can be duly important for other things. So really to get started, look at your resources, what's available. Is there any systematic way to start tracking this information and getting people talking, and then seeing where you can fill those gaps in the resources? I think that would be my suggestions to get started. I love Emily's comment. Thank you, Peace. Thank you both for your comments on here. Emily, so interesting. I'm always trying to brainstorm how to debrief them. Yes, that is actually a resource that is accessible. Our e-modules for critical incident stress management and debriefing I'm going to say this, but I'm not 100% certain. They should be available to anybody. They're on our university website that I know we can access. But I would be happy to share those. And I'll talk with Melanie in a way we can contact you all to have that information, including some of the websites I mentioned. We can send that out via email. But yeah, we'd be happy to share those. That took us a while to get started in terms of what we do. But what we did learn is that our faculty were not doing this all the same. And that's common, but like what is it that we should be doing? And is talking about it always the right thing? Is over talking about it the right thing? What setting should you be doing it in? Those are all things that we thought about when we started developing that. Okay, we're at 1 o'clock. I'd be happy. I'm going to stick my email here real quick. Sorry, there we go, into the chat. That way you all can have it if you need to contact me. And I'd be happy to share what I can for materials too. I really thank you all for your time. I know everyone's got a busy week. So thank you. And thank you, Melanie, for organizing and helping out.